I think choice is a big thing we've disagreed on.
The choice to get help, I feel like there still is some choice.
To most people, yes, there was that choice to take that first drink or to do the whatever the first time, but the second time isn't always a choice.
I think about the times I relapsed. There was a choice there. That's the part I struggle with, is that I had a choice. I knew what I was doing. I was not in that active addiction anymore, but I decided to use.
People who return, they're so hard on themselves and like, I had the choice to not do that. And society can be hard on people. Well, why did you choose to go back when you just got everything back? People don't understand triggers and brain chemistry.
Josh and Heather, welcome to the podcast, guys. You guys have such a unique blend of medicine and a clinical approach. Josh, you're the clinician, and Heather, you're the doctor. And so I love your guys' podcast and what you're doing. And I thought it'd be fun to be able to kind of back and forth just between those two different arenas that have some pretty big differences and obviously lots of parallels as well. But first things first, Heather, I'll start with you. Why did you get into helping people with addictions as a medical doctor?
Sure. It, first of all, was never my goal. I never intended on doing this. That's not why I went into medicine. But when I started my career, I joined a very rural primary care clinic with prescribers that were kind of in that generation of prescribing where they were encouraged to give lots of pain meds. I was not educated in that world and I was just not comfortable with it. And so fell into the world of opioid stewardship, first of all, in terms of monitoring prescriptions, appropriate prescribing of controlled substances, opioids especially, and really kind of breaking down why people were on pain medication. How can we help them in other ways, other pain relief type things? And when you start to look at opioid prescribing, addiction just kind of uncovers itself. And so it became, how do we help people who, are dependent on and or addicted to their pain medication, their controlled substances? And so started to do Suboxone or buprenorphine, the generic, and realized that the whole stigma of a drug for a drug versus, this is a treatment. So that kind of became where it all began, which was 2016 or so. And so our clinic was having a lot of success with addiction treatment as well as opioid stewardship. So got a lot into teaching, a lot of into mentoring, which then kind of naturally fit into getting boarded in addiction medicine. And that a lot just happened to build credibility. A rural family doctor, a couple years into her career, doesn't have much credibility in addiction world until you prove it. So did a lot of that and just really got to see how addiction was impacting our small town in all different ways, child protection, the jails. And then when COVID hit, our clinic really kind of shifted priorities. I mean, rightfully so in some regards, but patients with substance use disorder started to just kind of get pushed aside. I wasn't comfortable with that. So kind of took a different career approach and actually went and worked for correctional healthcare, which I absolutely fell in love with because it really taught me here's a whole group of people who essentially most of them have some type of a substance use disorder. So I got to learn where there were even bigger gaps in the system. It wasn't just prescribing of opioids and then going from that to heroin. It was where these people's lives had started, how they got started on their pain meds or drugs, and then how they ended up in jail. You get to hear their stories, and that's what really touched me and really kind of gave me the motivation to really dedicate my career to helping patients with addictions. Just another angle. So then I ended up leaving that job and joined a clinic doing outpatient addiction medicine. Again, I kind of committed my life here. We're going to take care of addiction. And that's when you learn that there's even other levels. Politics get involved. And it just still didn't feel right. Like I'm still not doing what I think I should do, and I'm still not doing what the patients need. But did uncover other barriers, health systems that just really don't want to help patients with addictions yet.
Can you talk about that a little bit more? The politics there?
For sure. Healthcare in general across the board has really turned into corporate business, all about money. You make money as a healthcare organization by doing big surgeries. you do not make money helping people with addiction, whether that's because they don't have insurance or they have, state funded insurance and the reimbursement isn't there. These are long clinic visits, so you're not having as many clinic visits, so therefore the revenue doesn't come in. To really care for a person with a substance use disorder, it is not as simple as here's your clinic appointment, meet with the doctor, here's your med, see you later. It involves a lot more people, whether that's a social worker to really kind of help find housing, find food, because patients are often unhoused and lacking in a lot of other ways. They don't have support systems. Having nurses and care coordinators to kind of check on patients, help them get to appointments, realizing the barriers. If you live in the middle of nowhere in Minnesota and your appointment with a specialist is an hour away, well, how are you going to get there? I don't think corporate medicine realizes that that's a barrier. And so things that I thought needed to be changed in order to really help patients were met with a lot of roadblocks, mostly because of finances and, the politics of medicine. And that was very hard to see, especially when I had seen what happens when people return to use or when they go into healthcare, they enter healthcare, and then they are met with judgment and discrimination and stigma. It's not welcoming for them. When you have a sign that says addiction medicine on the door, everyone knows why you're going there. That alone is hard for a patient who is that's the hardest part, is walking in the door. And when the door says addiction, it's harder. So I started working at Hazleton Betty Ford and doing detox withdrawal management prior to people entering residential treatment, which I also loved, because then you get to meet them at that moment where they said, okay, I'm ready, or maybe they were forced to go there, but you really get to hear and see that a vulnerability, if you will, and you get to kind of be that first person that helps encourage and find that one glimmer of hope for that person to hopefully help them get started on that journey. So I do that, but I also am back into a primary care clinic where I get to do primary care as well as addiction medicine. So it's kind of almost everything I love. I'm still not doing corrections again yet, but it's kind of, I've seen all angles of how patients and people with substance use disorders really have to engage and how much, support people sometimes need, and how we just, as a healthcare system, really do need to care for patients.
Yeah, that's an incredible story. And I feel like a lot of the people I've spoken to that are in medicine, I mean, I was in pre-med. My 5 closest friends are all doctors, dentists, or PhDs now. And very similar, maybe they didn't land in addictions, but definitely had that kind of refining and then discovering some of the corporatization of medicine, unfortunately, and some of the politics that come with it, and, trying to really do something differently and really make an impact in their patients' lives. So it's really, really inspiring. Josh, how about yourself? How did you get into helping people with addiction?
Well, I got a completely different story than Heather. I bring the lived experience from the world of addiction. It started out, I was a high school teacher and hockey coach, baseball coach, soccer coach. I coached everything. Social studies teacher. I was that stereotypical social studies teacher that coached everything. I was married. I had 2 kids, a dog, a house, just that, what everybody could, want. And I got hooked on opiates with a back injury. And I struggled with that for a number of years until it finally came to a halt when I was no longer, I had used all my resources to get the medicine from the doctors, and I was out. They weren't going to help me anymore. And I injured myself so I could get more pills, and that was the end of my marriage. And I ended up leaving the world of opiates and doctor shopping to enter the world of methamphetamines. I found that, after losing the life that I had built, I had a lot of emotional pain, a lot of regrets, and meth kind of killed that for me. I say it was the emotional painkiller that I had found that I was really looking for. And I lived in the meth world for about 7 years, in and out of jail, in and out of treatment, estranged from my family. I went 2 years without talking to my kids. It was just a really, really awful lifestyle that I had fallen into. And, it was so bad that, I almost forgot who I was, or who I could be, in the process. I forgot that I had been a teacher, that I had set out to help people in my life. And felt like that was my calling, that was my purpose. And whenever I would get into treatment or find some length of sobriety, I had a negative view of it. I had a negative view of my past, where it was a lot of shame based, a lot of regret, a lot of sadness, thinking, I'm not that anymore, or I can never go back to that because of my criminal record. I can't go back into teaching. My life has no purpose. A lot of poor me stuff. And then finally, it started to change a little bit. It wasn't a overnight change, but I started to think about the possibilities. Maybe I'm not going to be able to help kids with school stuff or coach them in hockey, but I can help people because of the training that I had, being a teacher and the experience I had. It makes it easier for me to communicate or work with people. And, I wanted to get into doing something with addiction. I felt, but I had been through so many treatments, and I just really had a lot of negative thoughts about counselors and everything like that. So I just decided that, maybe I'll just be a peer support person. And so I did that. And all of a sudden I fell into his job on a Native American reservation. And I was there for about, I don't know, 5-6 months. And I'm going to school to be a counselor, because even if I thought I wasn't going to be a counselor, I wanted to get, the experience. Well, a job opened up, and I was able to apply for a counselor position. And there is a special licensure for Native American tribal lands to be a counselor, because there's such a need, and they can't get, qualified candidates to be counselors on the reservation. So I ended up getting the job, and then I got the certificate, and here I am, and I'm finding this world as even more troubled than I thought it was. There's a lot of poverty, there's a lot of addiction in the area that I'm working at. So, I don't know exactly when it clicked, but I think I really found that this idea of being a counselor, it was what I was meant to do, at least in the time being, based on the fact that I had so much experience being a teacher, and I feel like I'm good at it, and I feel like I am able to make connections with the clients and build rapport, and so far it's been pretty good. So that,
it's amazing.
Like I said, my story is a lot different than Heather's. I went through the mix and came out, and I want to be the hope that people need as they go through their whole journey into recovery.
Yeah, I mean, even your trajectory kind of matches the typical client that Heather was saying she would work with, right? So it's kind of interesting how Heather, I'm sure this is the story that you've seen so many times, and Josh, it's obviously amazing that you found a way out and now you're helping other people. And I think the one thing that we all have in common, like kind of different stories and different angles, and I know you guys are working with more like opiates, opioids, that kind of those kinds of issues, more substance based, and mine's more behavioral. But the one thing I think we all have in common is we've identified a demographic that really is not being reached, and if they are being reached, they're not being serviced properly, and we're trying to make a difference in that regard. And I wanted to ask you guys about stigma. Why do you think it is that the stigma with addiction is so high still? I'm based in Canada. In Canada, we've had this movement for, I want to say maybe it's 10 years. It's pulled on by Bell, which is a big telecom company here, called Let's Talk, and they get very well known celebrities and other public figures to share about their struggles with mental illness. And it's definitely raised a lot of awareness about just how challenging this is. There's a hashtag around it. People share their stories on Bell Let's Talk Day. It's amazing. But I do find a lot of the conversations typically are depression and anxiety, which again, obviously there's a need for it. I'm not discounting that, but it does feel like addiction. And certainly the more specific you get, you talk about like all of a sudden you tell someone it's alcohol addiction. They're like, okay, there seems to be like a level of understanding around it, and AA, everybody knows that. But then you say it was a meth addiction, or you say it was a pornography addiction, and all of a sudden people are kind of like, don't know how to deal with it. And it feels like you get a lot more maybe confused looks or even judgmental looks. Why do you guys think the stigma is still so high for addiction?
I think there's a couple reasons for that. I think one is fear. There's a fear of, I don't want that to become me, or I don't want you to rub off on me, or so I think there's some weird element of fear. Or then there's the element of better than, like, oh, you have an addiction, therefore I'm better than you, because I don't. But I love your comment about the mental health. And I think that's where the stigma can either get stronger or less than. I think it's so strong because I think people look at addiction as a weakness, as, well, you aren't strong enough to not do that, or why didn't you have this coping mechanism, or you should have made a better choice. And I think that kind of underlines it all, which does go back to the mental health. If you're anxious and you're depressed and you're not getting the help you need, and we could talk forever about the stigma just around mental health, but if you're not getting the help you need for that, everyone's going to cope in whatever way, genetically or environmentally, is presented to them. And you can only stay strong for so long. And people don't like that because they think, well, you should do what I did, or you should do this instead. And they just don't understand. It's easy to say, oh, well, you should go do this. Well, if I don't have that support system, where was I supposed to do that? I don't know. I don't know if you are okay with me going on a really quick tangent. I have a patient
Please.
that perfectly describes this.
Okay.
I met this gentleman in my outpatient addiction clinic. He was like 23 years old, had been addicted to meth for 11 years, since he was 12 years old. And he had been to treatment a dozen times. And he is just like, I just can't do this. Like, I cannot get sober, is what he just kept saying. He's like, hopeless, like the definition of hopelessness, depression, all of the above. And I said, okay, let's go back. Tell me about the first time you used meth. And he sits there and he said, well, I was at home and his mom was being whatever in the back room by a new guy or whatever was happening. And he was sitting in his living room, which literally had a table and a couch, and that's it, very bare minimum house, no food. And he could hear what was going on, and he just had this breaking point. He couldn't deal with this anymore, and there was meth all over his house and drugs everywhere. And so he used the meth. And that's kind of where, that is how he escaped his life. Is he used that meth. It gave him what he wanted. It gave him that escape. It made him feel good. It let him kind of avoid what his life looked like. It helped him escape those icky feelings. And I said, okay, well, what should you have done in that moment instead? If you're saying that was a bad choice, what should you have done? And he said, well, I could have gone for a walk. I kind of looked at him. I said, okay, what else? He's like, well, I could have journaled. And I almost started laughing at that point, but I was like, okay, what else? And he kept trying to think of all these things. And I said, when did you learn all of those things? When did you learn you should go for a walk? When did you learn you should have journaled? First of all, what would you have journaled on? But whatever, like, when did you learn all of that? Treatment number 1 through 12, And I said, so as a 12-year-old, I think you had 3 options. I think one option was to go back into that back room and do, hurt somebody or try to break that up, which would have gotten you hurt. Your second option was to run away, kill yourself, something self-harming, or 3, use the meth to escape. I think you made the right choice. It's all perspective. If I look at that guy as a 23-year-old who's been to treatment 1,000 times and has used meth for 11 years, that's what society sees. They see that. They don't see that 12-year-old who had no other option. And that's where stigma comes in, is the fear of understanding someone else's story.
Just the power of having that compassion towards ourselves, right? And I think for people that go through addiction, you have to do it so much more, because as we're kind of discussing here, the world is not necessarily going to give you that compassion yourself when they hear about your struggle. So I love that perspective, Heather. Josh, what were you going to add there?
I was just going to say I was going to build, share what I've thought of, this whole time, because I was the one that was living in the stigma, feeling that stigma being shot my way. And I feel like, and this is part of the reason we started the podcast, is it's a lack of education. The lack of education that society has had about the issues with addiction, about why somebody might use, about, as Heather was telling that story, the origin of use. I mean, how many people had gone through the opiate addiction, or they ended up in a heroin addiction, and they have no idea where they started from. I know a lot of moms who got put on Oxycontin after they had a C-section, and 2 years down the road, they're shooting heroin in an alley because they were presented this drug that got them to the point where they were so addicted to it that they ended up having to do things that they normally wouldn't do to get the drug, because they were so addicted they would get sick. And there's this stigma about the drug users are doing this just to have fun, or because they like it. And there are so many people that get caught in addiction and then end up being in active use just to stay from getting sick, or to kill the emotional pain, or to prevent themselves from killing themselves. It's not a fun world to live in. It's not. You don't sit there and say, I'm so grateful that I'm hooked on meth. This is exactly what I wanted to do with my life. And that's the hard part, is that there are so many people that think that it is strictly a choice, or the idea of just stop using, just stop. I've been told that many times, but that's not their fault. I think of my family that couldn't understand. It wasn't their fault. They just they didn't have the information they needed in order to understand. And I think that's really what it comes down to in society, is that there's not enough information out there to actually get the understanding they need in order to have the compassion that I believe the addiction world needs. And I think that's, again, what Heather and I, saw as an opportunity to get that out there. And I think that's something that's the only way it's going to change. I believe that's the only way that society is going to change that stigma, is that if we get more educated on it. And I think that happened with mental health. I really do. I think that mental health is a little further down the road than what addiction is. I think mental health, had a similar stigma, and now people are starting to have more compassion for it. They're starting to believe it's a disease, and they're starting to be more empathetic about it. And I think that the addiction world is just a little behind that. There has been some movement in that, and there is a higher percentage of people that view it as a disease and view it as something that is not a choice and not a moral failing. But there's still a high percentage that do. So,
is there a subject or a subtopic in the addiction space that you guys have different views on or disagree on? I'm just thinking about the medical perspective. And I have to imagine, like, I know, Heather, just thinking about your background, there'd be so much to learn from you and glean from you. But Josh, is there ever anything where you're like, oh, that's weird that they taught you that, because that was not my experience as somebody who went through it? Or do you guys ever run into anything like those? Like anything where you don't see eye to eye? Just not that either of you are right or wrong necessarily, but maybe just different perspectives?
it's happened a number of times. Well, I think, I don't know how to exactly explain it. The choice to get help, maybe. I feel like there still is some choice. Heather, you go with that. I don't know how to word some of the things that we've disagreed on.
I think choice is a big thing we've disagreed on. I am very the disease of addiction. I will, you know, biologically, the biopsychosocial element. I am very into the brain chemistry and what happens and how there isn't that choice. Now, yes, is there usually that first time you used choice? Most people, yes. Now granted, it could have been innocent with the prescription, but yes, there was that choice to take that first drink or to do the whatever the first time. But I think the second time isn't always a choice. And so I think I'm much more strong in there's not a choice, whereas Josh has multiple times disagreed by saying there was some choice, like, which I think is backwards than I think most people would think. I think most people would think that the person with the lived experience would argue that there is no choice element. So we do differ on that a little bit. In terms of, I think what Josh was getting at in choosing treatment or choosing help, statistics are out there that says even if you force someone to go to treatment, the success of treatment is almost equal them choosing to go themselves. I think there's way more to that than the simplicity of certain journal articles might say. And so I think we differ a little bit when it comes to the choice of treatment. I think
So
there's
just to clarify, so you're talking
yeah.
about somebody being forced versus somebody in their own volition choosing to go. Like you're saying those, one of you guys thinks it's basically the same and one of you saying those are two very different things? Is that what
Yeah,
you
I
mean?
think most people just, logically would think, well, obviously if someone chooses to go to treatment, they're ready and there's that first step. And if you look at stages of change and go all geek out on that, that would make sense. There are articles that show no, people can be just as successful if they are forced to. And now, again, I
I
think
see.
there's more to it.
Yeah.
But I have had many patients who maybe were given that ultimatum: here, you go to treatment or you go to prison. So, yeah, there's a choice there, but there's really not. And people can be just as successful if they are forced to go. Now, what happens when they get there is different. They are going to choose to engage or they're going to choose not to engage. I think there's a lot more gray maybe in addiction than Josh does. And I think some of that stems from the inherent internal shame that people with substance use disorder have. There's stigma and then there's internal shame. And I think people don't see that, like, meaning society doesn't see that. They think, okay, you're sober now, you're normal and you're good and you can just move on. Whereas they don't realize that people who are now in recovery have a lot of self shame they have to deal with. Plus, they're being shamed from everybody else. And so, yeah, I just think there's a lot more gray in there than Josh does.
Well, and I think, what I see is that choice to get help or to not use. Once you use the drug, then the drug owns you. Then you really don't have that choice anymore. And I think that's what Heather has her opinion on. And what I struggle with is that whole idea of there is a choice to reach out and ask for help. There is a choice to surrender that drug to go get help, because I think that it's just too hard to have that, that desire to change when there's so much going on. And I feel like I should have been able to ask for help. That's where I think I differ, is that it's more of that self awareness and saying I should have been able to make that choice and I didn't. And then there's a lot of shame that I carry with that. And so I think it's probably better for me to listen to Heather and think that I really didn't have that choice, and just be grateful that it happened. Be grateful that I was able to go into a treatment facility or get the help I needed. But I think once you do choose to change, I think then choice continues to be in the process of that change, because I think about the times I relapsed. I mean, there was a choice there. That's the part I struggle with, is that I had a choice. I knew what I was doing. I was not in that active addiction anymore, but I decided to use. And so I think I struggle with that. I don't know what your thoughts are on that, Heather, but when I was 4 months sober or 12 months sober.
See, and that's where I also will differ, because he'll say I had the choice to return to use, or I don't use the same language as people in recovery. They'll use the language of relapse or sober, and I don't. So there we differ on just language. But he'll say there was a choice on going back. I'm not as black and white on that. I think there's more to it, brain healing and brain chemistry. And we know that the brain takes a while. Adulting doesn't come back because you've been in recovery for a day. And like that's a chemical thing. When I say adulting, I don't mean it as black and white as it sounds. There is brain changes and there's brain development and there's that executive function. And so when people return to use, I think I'm a lot more forgiving than Josh would be, because, people who return, they're so hard on themselves and like, I had the choice to not do that. And society can be hard on people. Well, why did you choose to go back when you just got everything back? People don't understand triggers and brain chemistry. And so that is another, I guess, point of disagreement.
Yeah, well, it's a fascinating conversation because I think choice and free will and in general, like these are topics that are very heavily debated, not well beyond an addiction conversation. So maybe a slight off branch of this, and I don't know if this would be more unifying or maybe this would bring the polarity out a little bit more. But I'm kind of curious now. But what do you guys believe are maybe some of the greatest predictors of addiction in your world? Like in my world with pornography addiction, truthfully, it's not very well studied and researched. And I was a university researcher. I scour the research monthly, really just trying to stay on top of it. It's still very heavily contested, but anecdotally and from the little data that is out there, and it is growing now. Early exposure, first stage of first exposure, that's probably maybe the greatest predictor that we have. There's not a lot of commonalities beyond that. I guess I'm just curious in your guys' world, what do you like? Are there any predictors? Or is there anything, Heather, where you're like, if I'm in front of a client and they say they had this growing up or this was the set of circumstances, I know where this story's going. Or Josh, is there anything like that for you, your own story and the people that you're working with, where you can say, yeah, different stages and phases of life and walks of life, but there's some commonalities. Maybe Josh, you can kick us off with this one. Is any obvious predictors or anything that you're always looking out for?
Well, the one for me is the most obvious one is mental health issues. When somebody, I do assessments on people that are looking for help to get into treatment, and there's a portion in there that talks about emotional health concerns, and almost without fail, it always has some major issues with mental health, or they undiagnosed is a lot. It comes into a lot. Undiagnosed ADHD when they were younger, and then they find meth, which is a fascinating thing with meth and ADHD, where it kind of is the medicine that they need, and it makes them feel better. If there's a
Does
lot
it
of
help them focus
depression,
as well? Does it give them that kind of,
yeah,
yeah.
yeah, and
Okay.
it just kind of works the way the medicine that they prescribe ADHD patients. It works in the same way. So if you're undiagnosed and you have never had that clarity, I mean that can become the addiction itself. Is like, wow, I kind of finally feel normal in a way. Um, and I think any trauma. We Heather and I have done an episode or two on the whole ACEs score, where it's a determiner of what your life has been like in trauma wise. Heather can speak to it more, but basically it gives you an idea of how rough your life has been, and I think that can be a great predictor. And I'm one that really wants to get on the other side of it, not on the when they've already started using or when they're trying to quit, but trying to do more on the prevention side. And so I like this topic about, what are some of the predictors? Because as a former high school teacher, I mean, we even going down to middle school and elementary as far as education to the kids, and then actually use some of the tools that we have to help the ones that are more susceptible, the ones that have more of the stacked against them and more of a chance to become, and one of them is family origin. If you have addiction in your family, there's a need to be aware of the dangers that come with that. And so, yeah, I think there's a lot, and I think Heather will add to that. But that's where I see a lot of that.
Yeah, I was gonna start with the ACE scores, the adverse childhood experiences, and family medicine. So I mean, I would deliver these babies, and you'd see these kids and small town, everyone knows everyone. Our nurse had a big diagram of drawing the lines of who's all
Family
related.
charts.
And
Yeah.
yes, so so you're like, oh, you're from that family. Okay. No, so I think, we know that brain development is huge. And in the first 5 years, especially, like the higher the stress, which is the whole basis of adverse childhood experiences, is all the trauma that happened to you before, I say high school graduation, you could argue 18, but the younger that traumas happen, the more, cortisol and stress exposure to that brain, that changes things. And whether that changes things to, if you've been in you have no adverse childhood experiences and you grew up in a very safe, loving, supportive home where you were free to be yourself and you were accepted and you could grow and explore with low stress, that is going to look very different than a person like the patient I told you about who lived in chaos. His brain didn't know what safety looked like. He's always going to be on edge. He's not always, there's healing, but in essence, he's going to be on edge. He's always going to be quicker to trigger. He's always going to feel, fear in that. And so I think that is one big predictor is what is your support system? What did your childhood look like? Genetics is huge. That's pretty black and white, but it's not universal. I mean, none of this is universal, which makes it that much more fun. Josh's A score is 0 and mine is 7. I didn't go down that route and he did. So it's always fascinating. And but yeah, that's kind of where I look first.
Yep. Yeah, it makes sense. Yeah, and I mean, again, even in our space, we don't use the ACE assessment necessarily, but I would totally agree with that. Like adverse childhood experience is definitely a very strong predictor, and even if it wasn't, like even if we had a Josh who's got a 0, still generally speaking, those upbringings and childhood dynamics, they always have some useful information on the treatment side. So on the go ahead, Heather.
No, I was just going to add that. Yeah, I used to always get A scores. I don't get them anymore because that can be triggering in itself, and it's lower utility to bring that out. But you ask, when you're asking patients questions or clients or whatever, you get those answers. The thing that I also noticed that's different though is the people who maybe have the lower scores yet still went down that route, if you will. That to me is almost a bigger predictor of, I don't say success, but longer term recovery. Like, what does their support system look like? Because usually, if they have a low A score, they usually have a pretty solid or supportive environment, and that recovery community or that recovery base, because that's huge. Someone getting out of treatment and they have nowhere to go, nowhere to stay, except the trap house, and that's their support, that's their family. They're going to have a lower success rate than someone that's got like parents that are like, yep, come home, we love you. So it can be used on both sides.
Yeah, that makes sense. That's a really good point. On the treatment side of it, I'm very curious on how your views on choice kind of inform that. Because Heather, you've referenced the brain science a couple of times. I'd love to hear about that. Truthfully, anytime I've ever spoken about brain science, either on this podcast or on Instagram, I always get just a huge swarm. Like we kind of know, like if we want to get a response, just talk about the neuroscience. And I think people like hearing it. Number one, like neuroscience has become very popular, and there's a lot of pop psychology around it. But I think what you were talking about is actually quite valid. I think people find it helpful to know, oh, there actually is just something that I'm combating biologically, and I'm not a bad person, and I'm not weak-willed, and like I think it can be very liberating for people. So I guess I'm just curious on the treatment side of it. What are you guys big fans of? What do you guys see to be really effective, and just in general, what are some of the solutions that you would heavily endorse in this arena?
Again, starting with opioids, I am a big proponent in medications for opioid use disorder, especially.
Yeah.
There is science there. When I did at one point in my career, I said that is just a drug for a drug. I said those words. It lasted all of 30 seconds. And then I got educated. This was way early on. But you have to give the brain back what it's lacking. And now the brain heals over time. That can go away over time. Does that mean everybody that's used fentanyl or oxy needs it? No, but you can be fighting yourself. We give insulin to diabetics, an analogy that everyone's annoyed with, but it's true. I think in terms of treatment and my approach is one, if we need to address or treat a biochemical, underlying disorder, like, we have opioid disorder, we have meds that can treat that. You don't want to do it. Okay, we'll find another approach. If we have underlying mental health, that's a genuine diagnosis. Everyone with meth use disorder, especially if they also use opioids, carries the diagnosis of bipolar. Most of them are not bipolar. I hate that. So if they have an underlying genuine diagnosis of mental health, we do need to approach that too. If we don't treat the mental health, whether it's simultaneously with the addiction treatment or before, or you have to treat that, because like we said initially, that's just going to kind of come back, or it's going to bring the addiction back, because that is how the brain is wired. We all have our go-to coping mechanism. Some people it is go for a walk, some people it's go to drugs. For me, I have an eating disorder for 20 years, so that was my coping mechanism. We all have our thing. And so it's address the underlying issue, but then I am very into preparing. So if I have an alcohol use disorder and I'm going to a wedding, okay, I need to know my plan prior to that exposure or prior to that trigger. The second I'm triggered, there is a chemical reaction that happens in my brain that's going to make me grab that alcohol, especially early in recovery. That is not a choice. That literally is a switch that flips when you're triggered. So if I have prepared for that moment, that switch isn't as strong. That it doesn't happen as quickly. There is a pause in that. So preparing for the triggers and preparing for life, if you will, being proactive is always one of my main approaches.
I know you guys have had some behavioral addiction experts on your podcast. And is there a chemical approach, like again, with like pornography addiction is a little bit of the wild, wild west from an academic standpoint, but something like gambling addiction, a little bit more established, or even video game addiction. Is there a chemical approach there as well for, kind of normalizing or stabilizing the brain?
And again, having an eating disorder, it's all the same chemicals, whether it's a behavioral addiction, and just watch the DSM-5, the behavioral addictions are going to take over, the diagnostic manual. There will be more addictions officially than gambling soon. They're all the same. The chemical reaction is all the same, whether it's fentanyl versus, pornography versus gambling versus eating disorders versus meth. They're all the same. Now there's stronger ones, meth we know is going to bump everything way higher. But it's still underlying, we get triggered, here's my coping, so there is the same chemicals. And I think that's where everyone doesn't, that's the education piece. It's, I can't give Suboxone to everybody. It's a different chemical, but it's the same ultimate end reaction.
What are some of those the chemicals that doesn't matter what addiction we're talking about? These are some of the neurochemicals that you're dealing with.
Yeah, and dopamine is always everyone's first one they talk about, dopamine, the feel-good hormone, if we're going to be simplistic, dopamine, serotonin, norepinephrine, and then you can break it down into the different versions of all of these hormones. Then you have your opioid receptor impacts, but it's mostly the dopamine, the serotonin, the norepinephrine type reactions.
Okay, and how does what you would prescribe to somebody deal with those different neurochemical levels?
Yeah, so Suboxone is going to deal with the opioid receptor, so that's not really going to be the same thing. In terms of other medications for treatment, there isn't any one direct, this is going to work for that chemical reaction, and that's the problem. I can give naltrexone to a person with an alcohol use disorder, but that doesn't really make all that much sense, because it is an opioid blocker. Further research now shows it does impact a little bit of that dopamine rush. So it doesn't block it. It just makes, okay, if I have one drink, it's not going to give me that same satisfaction as it did if I'm not on my med. So it can work for other addictions, but nothing's a guarantee. It's not, we kind of sell it as this is going to help with cravings. Cravings, are we going to call it a craving? We're going to call it a trigger. All of those things are, I see it, my body reacts. Pavlov's dog, the bell rings, my mouth salivates. I see my dealer's car go by. I see a glass of alcohol. those reactions, those chemicals, react. And that's where the meds are trying to approach. But it's not black and white. Nothing's black and white, it's very patient specific.
Yep, there's nuance for sure. Josh, I'm going to get to you. I want to ask one more question about this, Heather. And I don't know if you even have an opinion on this, but there's a huge surge now in interest in GLP-1s, and especially for appetite suppression and kind of as a weight loss tool. But lots of use cases for it, reducing cravings for pleasurable things that are not good for you, like, a drug or pornography. And I'm just wondering what your thoughts are on that and how they might impact some of the stuff we're discussing.
Yeah, it's fascinating. It's fascinating. I do prescribe them. I have a whole weight loss clinic I do now. And so I get to do non-official research in front of me, because nobody asks patient who goes to a weight loss clinic about their substances, but I ask everybody about their drug use, of course. It's kind of that same effect as naltrexone is what we're seeing, if I eat, I'm obese and I'm taking my, my semaglutide, or pick one of them, the GLP-1s, it slows, the food emptying my stomach. So therefore I can't eat as much. That's kind of the black and white, how it's supposed to work kind of deal. But it also blunts that rush that you get when you binge. So it almost slows down that eating process. So one, eating loses its enjoyment, so you eat less. Two, it slows it leaving your stomach, so you just can't eat as much. So it looks very similar to the naltrexone in terms of I use it, or I'm on my GLP-1 and then I use my substance, and it just doesn't have that same rush of enjoyment. And so it kind of cuts that edge of that rush. And when I say rush, I don't mean high. Most people who are using substances or addicted no longer really get high. We're chasing that high. But it blunts that chemically in the brain. Therefore, it slows the perpetuation of whatever the addiction is.
Got it. Very interesting. That's kind of cool that you have the weight loss thing on the side. I feel like that's like that's your R&D lab over there, and then you get to kind of figure out how it informs substance abuse. Very cool. Josh, circling back to the question, how about for you on the treatment side of things? What are some of the things that you stand by or you're very fond of?
Well, I think that co-occurring disorders is just a crucial part of the treatment process. As I said, I don't see a lot of clients that don't have a mental health issue or something underlying. It's just I don't believe. I know that people don't agree with me, but I just think that most people in addiction have a mental health issue that the drug or the alcohol or the sex or the gambling was curing. It's like with something we say in an AA or NA, alcohol wasn't the problem; it was the solution to my problem. And then, try and figure out what that problem was is the key to recovery, because it's not just about putting the drug down or putting the plug in the jug, is what they say in AA. It's really about finding the source and what is it that's making you have that power over you to make you go to the drug in order to get that relief in a way. And I'm not saying that people don't get high and don't have fun right away. It starts out as a good feeling, a great feeling, but it ends up being that it's a cure to something that is you have found incurable in your life, and now you find it, and it's helping you feel better. But then eventually it has taken over your whole life, and you have to take it in order to stay in a normal state. And I think that is the most important part of a treatment process is to find the source of the problem, and educate the people that are looking for help, because a lot of them don't even realize that. That whole idea of shame becomes a driving force in the addict's life to drive them back to the drug. It is trying to get you to go back to whatever it is that you are addicted to, and there's so much shame involved in that. That why can't I stop? Why can't I stop doing this? I have kids at home that are depending on me, and I'm neglecting them. That is not something that people choose to do. Like that they want to do that to their kids or want to hurt their family. And a lot of times is that they don't understand why. And so finding that why is a way of releasing that shame so that you can address the why. And I think that it needs to be something that's addressed right away. But at the same time, I think one of the things that we find in the MAT, or the medical assisted treatment, or is that the Suboxone for an opioid user, it will allow you to be able to get through withdrawals without being so sick. And so if you go into treatment and you have to go through the withdrawals, that first 2 weeks is really, you're not getting much out of it. You're going through the withdrawals, and now with fentanyl, the withdrawals will last way into 2 weeks. And not the hardcore ones, not the where they're sweating and muscle aches and diarrhea and all that, but the effects of the withdrawal will stay with them for quite a long time. Well, when you're in treatment, you're not getting anything out of the treatment if you're going through that. That's the problem, is that most treatments are 30 days, and half of that time you're dealing with the withdrawals from whatever you're withdrawing from. And so, that there's not that magic answer for meth or alcohol, that you're not going to go through the withdrawal. But at that time is when you can start finding, as a clinician, you can start finding where the issue really is, so that you can be prepared to deal with that when they are ready, when their mind has gotten back to a place where they can actually retain this or actually take it in. And then you can actually start working on that so that they don't feel that shame of why am I a meth head? I've heard that so many times. Why am I a junkie? I'm a junkie. These are the things that we label ourselves as that keep us sick. And so, so long answer to the question is finding the why in the whole addiction process, I think, is a crucial part of the treatment.
And again, I'm curious because I know, like Heather was kind of saying with the medical side of it, even though medicine can be very, very black and white, like if you administer the medication, this is what happens to the receptors, this is how the body responds, and yet it doesn't necessarily mean it actually has a behavioral change. There's so much individual variance, and I'm curious with you, Josh, when you are working with people, you're helping them get to that why, or discovering that, that void emotionally, or that thing that they were ultimately trying to satiate. Are there commonalities that come up? Are there things that tend to pop up when you do really get more to the heart of the matter? Or do you find that generally there's a lot of individual variance and it's not really that obvious? It just depends.
Yeah, I don't see a commonality. I mean, a general basis of it is, like some can be childhood trauma is a generality, but I think, this is like, this addiction issue is so individualized. Each person has a different story, so each person really needs an individual plan. It always bugged me when you go to one treatment and then the next treatment, they're doing the same thing, and you go through the same thing, and everybody's being treated the same way for a disease that has no, you cannot take one addict and another addict and they're the same. When they're not the same, they need different help. And so it's hard because, the resources we have as far as staff wise, and, the fact that one counselor is working with, you know, 12, 12 people, and you're supposed to meet with them, every other week. And, how do you get to that level of individualized? I was a special ed teacher at one point, and so they have the individual educational plans, IEPs, and each one is different. And I believe that's really what we are trying to do in the world of treatment. It's just the resources are so limited, and so we do the best we can, but it's so individual that's what I really think is missing, is that each person needs a separate plan, and it comes from such different areas, whether it be mental health or trauma, or issues with regret, loss, deaths. I have so many people that are still mourning. They didn't grieve their loss of their brother that died tragically, or their mother that died early, or their best friend that committed suicide. There's so many different stories that led to that person's addiction. And so it's hard to really narrow it down or say that there's one common theme to each person that's in addiction.
When you guys look ahead, the one thing that you guys definitely have in common is your passion for the subject, and clearly a zeal to make a difference and to maybe disrupt some of the traditional approaches. What if things really changed effectively in your respective fields? What do you feel like things would look like? What would be happening? Maybe let's vision cast a little bit and say 10 years from now. How are people approaching addictions and treatment? And obviously we talked about stigma, such a big part of this conversation. What are some of the changes that you guys think would be taking place if you were successful in continuing to champion maybe a bit of a different approach to addiction?
I mean, I think it has to be a very comprehensive approach. And, like Josh said, it's everyone's different. And so you need to have everybody at the table for each patient, and, obviously not sitting at like a legitimate table, but, you need to have, a support system, whatever that looks like, has to be engaged. And so how do you help engage a support system? And maybe someone doesn't have that. Well, peer support is crucial. You need to help a patient build a community. So do we have a welcoming recovery community? People like going to the Twin Cities when they're in recovery, some of them, because there is a very flourishing recovery community where there isn't in rural Minnesota. Some people avoid it because they use drugs there. But, it's what does a good, healthy recovery community look like? Well, therefore, the community needs to support people without the stigma. You might need the medical aspect to help with their mental health and or their medications for their addictions. And you need people to understand that. So then, I can talk to a surgeon and say, here's the deal. This person is in recovery because it's all over their chart. They have this history of addiction, but they need the surgery. And so you better treat them the same way you treated that person who had the same surgery 5 minutes ago. So you need to have everyone kind of understand that and be welcoming, because you have one mean doctor who's going to judge you. You could set someone back a lifetime, and then you might need that. You need social services to be at the table to help support, whether it's the homelessness or whatever else it would be. So you just need you need to have people across all sectors supporting the idea that everyone's a human and everyone has same basic human rights, regardless of what their disease is, whether it's addiction or blood pressure or whatever it might be. And every patient needs to be comfortable in every sector, and then we could whole talk about prevention. And that's also important though, because if we're going to break that cycle, Josh works on the reservation, which is the, very obvious example of generational trauma and, repeating the cycle of familial addiction. So how do we address that? Well, we need to have culturally sensitive care as well. We need to have trauma-informed care. We need to have prevention so we can break that cycle for families and for communities. And it doesn't have to look a certain way.
Yeah, really well said. I totally agree. Josh, how about on your side?
I'll just piggyback on what Heather was saying. The prevention side is where if I could champion some change, that's where I would go. I mean, obviously, with being a former teacher, I see a lot of possibilities in the role of education when it comes to the world of addiction. And one of my earlier dreams was to get back into the school as a LADC, licensed alcohol and drug counselor, that was in the school. And I thought, well, half of my time could be done counseling students who either are in addiction or have been in addiction, or students that have family members that are in addiction, doing one-on-one counseling. And then the other half doing strict education, having classes where the kids come in and they learn about the drugs and the alcohol, that the dangers that they present, because I didn't know exactly what I was getting into when I was a kid. I drank quite a bit when I was in high school. I was really, putting a real damage to my brain and stunting it. And, the earlier you start using, the more likely you're going to fall into addiction. And even if we could prevent that start of use until after high school. Their brain has developed so much more so that they're able to make conscious choices as they go. And, and if we can use some of the information to help prevent some of this stuff, just by educating the students and educating them all the way down to, maybe fifth grade and starting it that early. I would love to see a curriculum that includes addiction. It includes addiction education, and so that we wouldn't have as many people that we need to service in the world of treatment recovery. I don't think it is ever going to go away, but I think we can save a lot of people from having to go down the road that some people have to go down. And there's so many deaths that happen every day. It's like 308 people die every day of from addiction, from either overdose or suicide or something like that. And that's a jetliner. That's a 747 going down every day. And if that were happening, to people that that are regular people, there would be an upstorm about how can we fix this. We need to address this, and it seems like that's not the case. But if we start taking it more seriously, maybe we can get it into the education world and have some prevention. And the treatment side, I could go on and on about things that I would do differently, because I've been to 9 different treatments and I feel like I could change this, change that. But I'm just not that qualified to make those. I don't know the whole system that great, and I'm learning that now as I'm working in it. That we're doing the best we can. We're doing the best we can, and we're trying to save people. But yeah, so if I could change anything 10 years down the road, addiction education would be a required curriculum in our schools.
Yeah, that's beautifully said, you guys. This is amazing. You guys are doing such good work. I'm so glad you guys have a podcast together as well. I can only just imagine just the impact you're having on your audiences. If people do want to go check out the podcast or find out more about you guys, what's the best way for them to do that?
Well, the podcast is Addiction to Recovery. So it's addiction and then the number 2 and then recovery.
So we'll put a link in the show notes to the podcast. And yeah, Josh, go ahead.
Oh, and I wanted to say that Heather has a new book out that's called Trauma's Worth, and I think that it's it's going to be such a help to people that have gone through trauma, and it's going to be very applicable to people that go through addiction stuff. And I think that it's something that people will be able to use as a helping tool. And so I just wanted to give her that little nod.
Yeah. Heather, how did you leave that out? That's important. What's the book called? Trauma's Worth?
Yes.
Trauma's
Yeah,
Worth. Perfect.
Yeah, so it's exciting. Just came out.
Is it on Amazon?
It just came out on Amazon. Otherwise, there's a website, booksbyheatherbell.com, but it is on Amazon.
Okay, perfect. That's great. So we can link those in the show notes as well. Guys, thank you so much for your time today. This was awesome.
Thanks for the opportunity.
Thank you so much.